Hello, everyone, and thank you very much for joining today's webinar on integrated care systems, focusing on digital transformation and health and care. My name's Paul Grant from Mott MacDonald, and I'll be hosting the webinar today. And we've got a really exciting agenda prepared with some excellent speakers who are all going to approach today's topic from different angles. We scheduled 1.5 hours for the whole event. During the first half of the session, we're going to have some presentations from our panel, which consists of Steve Peddy, who works as a care and health improvement advisor for Dorset Council and does a lot of work with the local government association and NHS England as well. Dr. Malti Varshney, Director of Strategic Change and Population Health at Kenton Medway ICB, and Professor Sam Shah, who's the Chief Medical Strategy Officer at Newman and the former Director of Digital Development for NHS England. Following the speaker presentations, we've set aside 30 minutes for a Q&A session. So whilst you're watching the presentations, please use the chat to post your questions and share your thoughts, and then we will address them at the end together during the Q&A. If you see a question that you think is particularly good or very similar to the one that you wanted to ask, please like it. So give it a thumbs up so you can see which ones are the most popular. And we really want to encourage a kind of a frank and open discussion. So while we'll be recording the presentations and sharing them after the events, the first part, we won't be recording the discussion that follows afterwards to allow for a Chatham House rules, so kind of a free and open discussion. To ensure a smooth experience, I'd like to go over a few technical aspects before we kick off. If you encounter any technical issues or have trouble hearing or seeing the content, please let us know through the chat box and our technical support team will assist you. And then you'll see that your microphones are automatically muted to minimize any background noise, people's dogs barking or children shouting. However, please feel free to keep your cameras on if you're comfortable doing that so that we can see your smiling faces. So in terms of digital health and care and transformation, we put this together because we think it's a really important issue. Currently, we don't have the capacity or the capability to deal with huge demands placed on the NHS and social services. We know there are now over 7 million people on waiting lists, and there aren't enough doctors, nurses, allied health professionals, social workers, council support workers, etc., to deal with this. So technology, when used well, can help overcome these challenges. And digital health solutions can bring about better patient care, better patient engagement, more efficient healthcare delivery, automate a lot of administrative processes, and hopefully reduce costs. So the future is looking very bright if we all put our heads together. And that's really the purpose of today, to hear some new perspectives and discuss our experiences as well. So let's move on to our first talk. And I'm going to hand over to Steve, who's going to talk about the digitalization side of social care. And I think this will be a really interesting talk. So over to you, Steve.
Great, thanks, Paul. And just to explain, because my sort of profile's got a little bit merged, I'm a senior advisor in a program called Partners in Care and Health, which is based in the local government association, and I'm a support Department of Health and Social Care and NHS Transformation Directorate as a senior advisor. I'm an ex-director of adult social care, and I do some work with Dorset Council. So just to explain, I've got a number of different hats there. This might be a slightly minority interest presentation. I hope it's not. I hope it's got something in for everybody. The presentation that I'm going to give you is something that I've originally designed for senior leaders in adult social care, in the hope that I can connect with them as digital leaders. They're primarily care leaders, of course, but for the uninitiated, local government doesn't work like the NHS. It's not a single organisation. There's 152 different local authorities, each with their own elected members and political administrations, and it's quite difficult to get social care to move together. But social care's got the same sorts of problems as the NHS in terms of needing to work smarter to get through its work and to give people who need it, who need care and support, their gloriously ordinary lives and what they deserve to have. So I'll explain this as we go through. And by the way, if you work in the social care sector, hello. And if you work in the social care tech sector, I know we've got somebody from Mobilize on the call. If I don't name check you, forgive me, because I might be name checking somebody else. But so we've got some fantastic products out there. So let's go to the first slide, please. So where I'm trying to connect with people here is adult social care hasn't been inspected for about 13 years. That might be a surprise for you. Providers in the social care sector, which is about 95, 96% of social care, they've all been inspected regularly, but local authorities haven't. And so there's an annual assurance program. It's a bit like Ofsted that is being started this year, and it's in pilot stage with CQC at the moment, the Care Quality Commission. And these are the assurance themes. The first one is working with people, which is all about how we connect with people. It's about how we support those people, how we assess and plan their care plans, how we review their care, how we do prevention work. IAG means information, advice and guidance. How do we give them the information that they need to live their ordinary lives? The second one is called providing support, which is all about commissioning and market shaping and sustainability, workforce capacity and so on, partnership working. The third one's about safety, which is really in our world about safeguarding and continuity of integrated care. And the fourth one is about leadership. And so it's all about, as well as innovation, it's about some of the bog standard stuff in leadership, governance, management, sustainability, a learning staff group and so on and so forth. And next slide. So what I want to say, and I always say, is that I'm a social care professional primarily. Social care is a people-centered world. Technology is a means to an end. It's not the end. And I'm citing examples throughout this presentation of ways of helping people to support other people who might take up care and support and their carers, or ways of directly empowering those people to help themselves to have ordinary lives. And so we'll do the next slide. And now I've said that. And then this slide is the first of the themes. So I've just mentioned the four themes. This is the first of the themes, working with people. And before I go on, I'm just going to mention in the grey text underneath the top green text, there's something called what good looks like. So that's what WGLL means. And what good looks like, I'll come back to at the end. That's like a digital maturity assessment tool for social care services. And if you work in an ICS, you might recognize that terminology and the 7 themes as something that you're already familiar with in an ICS, ICB, integrated care arena. So what I'm trying to do throughout this presentation is I'm using the 4 themes of our social care assurance process, and I'm matching them underneath to what's in the digital maturity assessment. So in this one, I'm matching our theme 1 with themes 5 and 7 in what good looks like. But I'll come back to that. So now I can carry on properly. So the first thing is to say, under this working with people, which I've outlined, is about good information, advice and assessment, planning, reviewing care. I'm saying to our social care leaders, ask yourself, are we maximising the power of technology to support people to gain and maintain independence, privacy, dignity, all the sorts of things that we want for people in social care through technology? Are we being smart about information and advice? There's a huge amount of demand coming through. Some of that demand can be managed through harnessing technology to manage the needs of those people. Not everybody actually needs to have a package of care and support. They sometimes need advice and information. They might need financial advice and information. They might need to know where to go and get community resources. Not everybody is doing the best they can in that arena. Assessment. We've got major backlogs, 500,000. I know Paul mentioned a figure of 7 million people waiting in the NHS. Perhaps pales into insignificance, but 500,000 people waiting for an assessment is a lot. We've got some brilliant tools for supporting self-assessment in adult social care, whether that's a care assessment for the person themselves, an assessment for an informal carer, an assessment about your finances. What do you need to contribute towards your care costs? All of these things can be automated. There's no need to have such long waiting lists when these sorts of tools are out there, but it would be perhaps a surprise for you to know that 3/4 of local authorities don't have an online assessment tool. 4 out of 5 local authorities don't have an online financial assessment tool, and so people do enter the financial assessment part of social care and abort when they find out how much they've got to pay towards that care. So next slide. This was just a survey into that Mason Advisory did. So I'm going to skip that slide and go to the next slide. So the key questions on this theme for councils is, does your adult social care online strategy align with your corporate, your wider council digital strategy and website? How much is the rest of the council helping you with that? How are you working with care, community health and technology providers to keep online information and advice about local activities and care and support options up to date? Because so much of people's care needs can be met by community organisations that people don't know what's out there. How does digital fit with your assessment strategy? There's different ways of getting through that demand. Are demographics and digital inclusion and user design principles being built into that strategy? And are social work professionals confident in using and championing technology for information advice and that assessment? So next slide. Because I'm going to go now into the second theme, which is all about commissioning and making markets and market sustainability. And again, there's just loads of tools out there for local authorities, which are around place-based data and market intelligence. But not everybody has adequate systems for gaining that market intelligence, doing market analytics, comparing their costs with other councils, and having the information to help them to shape those markets, but they are out there. Secondly, shared care records. So records that are shared across health and social care providers. Some areas are really, really advanced in this space. And, as I've said, I do some work in Dorset, and the Dorset Care Record is really extensively used. In fact, social care is the highest user in Dorset of shared care records, higher than NHS colleagues, because it's a really invaluable tool, particularly around safeguarding, to be able to see what interventions everybody is having. But it's incredible to think that there isn't everywhere a shared care record isn't prioritised. There are systems supporting capacity and flow. How well are we using that sort of digital technology? We know that there's underutilization in downtimes of providers, and yet people can't get a provider to get people out of hospital. And then with a workforce of 165,000, Skills for Care say there's 165,000 vacancies in social care. How many leaders in social care can say that they're exploiting all the benefits of digital technology to address that? And I'll go on to say a bit more detail about that. Next slide. These are some of the systems. This is not an extensive list, but in terms of getting place-based data and market intelligence together, we have things like PAMS, which is the Provider Assessment and Market Solution. Some local authorities have got that, some don't have it. We've got e-brokerage solutions. Those are some examples there. We've got matching services like Pairly. Give them a name check. They're a good one. We've got ways of people matching carers with their support. So we've got Mobilize is a good example of that, or Bridget. There's lots of different ways to enable a better place-based data and market intelligence and matching support service available to people. Next slide. And then I haven't got time to go through all of this, but here's a list here, and it's not a complete list, not an exhaustive list, of ways that that home care conundrum can be managed. So, in terms of if you employed all of those, the evidence is that you get about 20% of your home care back. through use of route and zonal optimization, digital scheduling tools, getting all your data up on GIS mapping and working collaboratively across providers. So the evidence is you get about 20% back. But how many local authorities or how many ICB areas are actually taking up this opportunity? And instead of which doing the usual things like employing more overseas workers, paying more, using off-contract providers and so on, which is just unsustainable. Next slide. And then some areas, this is an example from the Northeast, where they've got a real-time capacity and flow management system using handheld devices to know what's available in real time, and simply, safely, securely, as it says, using digital to help with the discharge to assess pathway. Next slide. So in this one, the key questions for social care leaders in councils is, does your commissioning strategy make the best use of that technology so that you can get the right care and right support in the right places at the right time? Are you working with care providers and technology suppliers cooperatively? Are you jumping to extraordinary solutions to workforce capacity challenges when easier or smarter solutions are available? Next slide. This is theme 3. This is about ensuring safety. So what we're saying to our social care leaders and professionals is, are you maximizing the power of technology assistance to support people to gain and maintain safety and yet privacy and dignity, because that is so important. And also in this safety arena, how about avoiding unnecessary crises? Are you thinking about this in a proactive way? Because there are ways to do that. So have you got the digital tools to ensure a standardized and consistent approach to quality assurance or not? I've already referred to shared care, but that's the big gain. I think shared care records, big gain is in safety and safeguarding. Unnecessary crises and system failures. There's technology enabled systems, monitoring, data analytics, remote monitoring devices that you can put in people's homes. And in terms of digitizing care in the care provider sector, I'll go on to say a bit more about that in the next slide. So I talked about shared care records, but just in terms of digital social care records, which is what DSCRs stands for, and EMARS, which is electronic medication management systems, it would be a surprise probably to you if you're not in this industry to know that we're just about getting up to 60% of our registered social care providers that are on an that are on a digital social care record system. And about 20% of registered providers, sorry, can you go back? And 20% of registered providers are on pen and paper. Is that safe? It isn't, is it? And actually, CQC are so conscious of this that they've said to providers it's highly unlikely that you'll be able to maintain your good or outstanding status if you don't go onto a DSCR by your next inspection. So obviously, it's really easy to get medication management wrong, and we have 80% of our people in care homes are over 65, and they tend to have a lot of medication, as a lot of people on the call know. So it's easy to get that wrong. And it's really much easier to be able to audit that system and get it right if you've got an EMR solution in place. So the next slide is just to highlight, as I said before, you've got systems. Again, this is not an exhaustive list, but Just Checking or Lily or other passive monitoring systems are out there. They will learn. They can give you data about how people are moving around their house. They can give you alerts to if somebody's got stuck in the loo, or if somebody spends too many times going to the loo or whatever. And it's really there's such an amazing world out there that's available in social care to be able to use to help you manage people more safely and even to get proactive. So next slide. So the key questions are, every area has a safeguarding adults board. It's a meeting of all the senior professionals, but they don't spend much time talking about digital. Sorry about the typo there, but about how, as a system, they can build in better quality assurance through technology, and to discuss the strategic importance of joining up critical information about the same person, or the dangers of not having critical information about the same person joined up across different system providers. And we all know there's massive interoperability problems. Even in a social services department, if you've got people having a mental health service in the NHS, you will find that even though one system provider owns both services, those two systems are not interoperable. So you need a shared care record system to be able to join those up. So the next slide, please, is the final theme, which is about leadership. So it's about governance, management, sustainability, learning, improvement, and innovation. And so we're saying, ask yourself as a leader. Well, not ask yourself, am I a great digital leader, but ask yourself, because CQC will ask you about whether you are allowing people to be empowered. And what is the means of that? And are you allowing people to get the technology-enabled care that they need, as opposed to just providing people? And sometimes that's very stifling. Sometimes it's not very dignified. Sometimes it's not what people want. Are you data-driven? Because if you're not data-driven, why are you doing what you're doing? And how do you know whether you're doing things well or not? How do you know whether you've got the outcomes that you need to get? The workforce and optimization is one that I've gone into already. Quality assurance and safeguarding, market and cost management, and system integration. So you'll be asked about all of these things. CQC will not ask you whether you're a great digital leader. They'll ask you how you've performed against those outcomes. But there are smarter ways of achieving those outcomes. So let's just go back to what good looks like for social care. So what good looks like was originally conceived as a 7-theme or 7 success measure outcomes for ICSs. It's now part of our adult social care scenery. We published this in May. And so the great thing for the integrated care partnership community is that adult social care in digital world is speaking the same language as the ICS, because we're all using the same thematic approach: well led, ensure smart foundations, safe practice, support workforce, empower people, improve care, and healthy populations. And hopefully, as I've gone through this presentation, you'll have been able to, if you're more familiar with this 7-theme framework, you'll have been able to click. There's a resonance in terms of what we're doing under the annual assurance framework. So that was published in May. And then if you go to the next slide, what's been going on behind the scenes in the local government association is we've been working up a digital tool, which at the moment looks a bit two-dimensional, as in this is an Excel version of it. But this is for local authorities, and at the moment it is for local authorities to help them to on their self-improvement journey, their digital self-improvement journey. So along the bottom, you will see that you've got the themes, and then in terms of the vertical, you've got the criteria to meet what good looks like, and then you've got a 4 options in terms of where you're at. And if you could see more of this, because this is just obviously a screenshot, you will see that it gives you your examples about what that would look like. So it's not just about what good looks like, it's about what in progress looks like. It's about what well established or what advanced looks like, or indeed what not started looks like. That's not one of those ones that's been picked on that screen grab. So next slide. Our key questions for social care leaders is: have you thought about how being a great digital leader could help you to illustrate your credentials as a system leader, a creative thinker, a workforce and capacity planner, a good partner in that ecosystem, an enabler? of empowerment for people who want to live their gloriously ordinary lives. Next slide. So in summary, this has all been about digitally enabled lives, not really about digital itself. It's that technology offers potential solutions at multiple points of intervention to support people to lead those ordinary lives. Secondly, as workforce challenges persist, tech can help you address immediate priorities as well as longer term sustainability. Thirdly, using technology to help learn and innovate and find your way out of those workforce challenges, those managing risk challenges, helping to plan support for the right people in the right place at the right time. Well, that's just good leadership. And digital technology, finally, it's a core solution to supporting a good assurance outcome. It's not an afterthought, best left until all of that important stuff is over. It's actually going to get you there. I think that is it. Just move the slides on. That's it. So that's me. If you've got any questions after this session today, that's my address. More than happy to respond by email, but I'm going to hand back to you, I think, Paul, now.
Brilliant. Well, thank you so much, Steve. That was a really interesting presentation, and it's fascinating to see all the things and all the potential that can happen in the world of social care and how digital is an enabler, but it's not the only thing. As you say, a lot of it is about the people as well. I was going to ask you a question about the future of the what good looks like framework, but I'm going to leave that to the end because I'm conscious of time with our agenda. But thank you very much for that talk. That was really good.
Thank you.
So next, we are going to move on to a presentation by Dr. Malti Varshney, and she's going to talk about population health and prevention and digitization. I think this will be another very, very useful talk. So over to you, Malti.
Lovely. Thank you, Paul. And it's really good to be here. I'm Malti Varshney, as Paul said. I'm Director of Strategic Change and Population Health. My background is I'm a public health consultant by background, but I've just recently joined the Kent and Medway ICB from a role in the national NHS, where I was working as Director of Personalised Care and also leading on the implementation of the fuller stocktake. So my presentation today would be grounded in my experience of what I have learned over the years from public health, but also as a director of clinical transformation, working in London, that how we bring it all together for the benefit of the patient. So the slide that you have that is in front of you is really about that. It is after behind every data is an individual, and behind every individual is the various outcomes that individual is experiencing. This is a story, a case study, which many of you would be familiar with. Next slide, please. Yeah, this is a case study that you would be familiar with because we see these stories, hear these stories with the aging population. Comorbidities are becoming really, really prevalent, and how the patient experiences the interaction with the NHS is quite important. So this is what I was saying, that behind every data there is an individual whose data we are capturing. Next slide, please. So we have to really bear that in mind, that when we are designing our interventions, when we are designing our clinical pathways, giving it a service user lens, how will their ill health be prevented? How can we make the interventions that we do more personalized care? What would how can we really get rid of the organizational barriers to improve the experience? Because really the purpose of the NHS is about improving access, experience and outcomes for our population. If I could move to the next slide, please. If I could just contextualize it in the current ICB that I'm working in. The ICB is a complex system, like many other ICBs. We have two-tier local authority, unitary authority, as well as an upper tier with 12 districts and boroughs. The population is around 2 million, and as you can see from the population graph over there, that our aging population is slightly higher than England average. We have 4 places, and these 4 places are coterminous with our acute care providers, but they're not necessarily coterminous with our 12 districts and boroughs. And then, as you can see, that we have coastal poverty, and there are some most 10 deprived wards across England are also in our Garden of England in Kent. Could I move to next slide, please? So looking at our population projections, we can see that our population requirements and the needs on healthcare utilization as well as social care are predicted to increase, particularly for the older population. Again, I would point out to you towards the top of the population pyramid, as you can see, that our over 60 population is projected to be higher than the England average. We have to bear these things in mind as we are designing our solutions to the challenges that we are facing. Can I move to next slide, please? And these challenges can only be addressed through collaboration across the primary, secondary, social care, and hospital care. Plus, I must definitely mention our mental health providers as well as voluntary and community sector. Because what we are really aiming for is, and hopefully you all would be familiar with this concept around the neighborhood, which is kind of looking at around 50 to 70,000 population, where the neighborhoods, their purpose is about bringing the primary care together, primary care networks together, but working with their local partners in that space, understanding their local population needs, and then bringing those agencies together to address those population needs. And of course, there are things that need to be done, such as the acute care services provision, which needs to be done at place level, and then there are specialist services that needs to be done once for the 1 to 2 million population. Can I move to next slide, please? Through this slide, really what I'm trying to demonstrate is that by taking a life course approach, starting well to giving a really good depth to those who need it, the vision of this integrated neighborhood team, integrated care system is that we move away from more reliance on acute care services to more into community plus prevention services. Can I move to next slide, please? So colleagues would be familiar with the Fuller Stocktake, which was at the heart of it. Fuller Stocktake recommendations were recommending this integration that I have just been talking about. And the Fuller Stocktake had 3 offers. That is the way it articulated. It was advocating that should we be able to provide integrated services across the place, neighborhood, and system, there should be a good offer to the population be made where the access to urgent care can be done in a timely manner, in a seamless manner, and more around episodic care, i.e. around the urgent care. Then if they need continuity of care and complex care, through the preventative, proactive, personalized and preventative care can be provided. And that really genuinely requires good data integration and good data interrogation. And then thirdly, that if we were able to do that well, we should be able to provide preventative approaches to our population. And that by that preventative approaches is not just about primary prevention as in smoking cessation or doing NHS health checks. It's about optimal uptake of secondary prevention, optimal uptake of management of hypertension, lipid management, etc. So it's the prevention in its entirety is what it's advocating. And of course, none of this you would see from the enabler side of things, that none of this is possible without integrating, making sure that the estates is integrated, and more importantly, the data and digital side of things is integrated, because we need to understand our population needs, as well as looking into how do we break the barriers across the management, across the provision of services through working with a collaborative workforce. Could I move to next slide, please? But the reality is that healthcare services only address 20% of the looking towards the health outcomes. The 80% of the health outcomes are really determined by the wider determinants. And hence it is extremely important that we work with our partners in the system. Can I move to next slide, please? What I'm trying to demonstrate over here is colleagues would be much familiar with the diagram on the left-hand side, which really talks about population health. And that is that the individuals or the population's health is really determined by a combination of factors, the access to health services, but also the wider determinants. You may or may not be that familiar with King's Fund approach to population health, which is really bringing together all these disparate parts together to say we excuse me, in order to really improve the health of the population, which is the aim of the ICSs, we need to bring these four things together, which is about understanding how do we work around the modifiable risk factors, working with local public health teams, how do we look into the wider determinants, which does include things such as housing, employment, benefits realization, etc. Looking at where the communities, how do we work with our communities, and that is tapping into the potential of VCSEs as well. If I could move to next slide, please. And in a two-tier two-tier system like Kent and Medway, we really need to work with not just the upper tier, but with also our partners in districts and boroughs, because our partners in districts and boroughs are able to provide that support together of the services that I said they are able to offer. Moving on to next slide, please. So as I said, behind every individual, the data is there is an individual behind that. And many a times, Nude, if you could do double click for me because the other two diagrams will come. Thank you. Many a times, what we really have is disparate sets of data across the system. And the key really is about how do we join these data systems and the data to tell a coherent story so that we can genuinely develop insights and move into action. Can I move into the next slide, please? And therefore, what I'm trying to demonstrate through this diagram here is that we need to build data. We need to really understand how does the data flow right from a patient through to aggregated through to a level where research and evaluation or quality improvement levels can take place as well. So as what you would see through this slide, the data starts with the individual, which is about things that we have just heard that Steve was talking about, remote monitoring, etc., and at GP practice. How is that data used to improve direct patient care? How is that then data used to look into used or utilized to segment the population to inform the policies and interventions? How is that data used to develop clinical interventions and quality improvement projects? And how is that same data then informing the ICB level of service planning as well as informing how do we undertake research? Moving on to the next slide, please. So rooting it back to the system and the reality of my system, we do have challenges, and our challenges are no different from any other ICS. However, moving on to next slide, please. What we have found is that if we take this data really well and understand this data, we can look into the healthcare utilization and how the challenges that with the patients that we see, how in the ED, where the pressures are coming from, what is behind that and where the interventions can take place. Next slide, please. Interventions. Now, this is a really important intervention because you would be very, very familiar with, hopefully in all our systems, we are talking about how do we establish integrated neighborhood teams. It is important that integrated neighborhood teams are nested within that place and within that system. So if I start with the outer square, which is about the system, it is crucial that the integrated neighborhood teams are not seen as a standalone thing. Using the data pyramid that I have just explained, we need to understand what services we need to provide at universal level, what services we need to provide to those individuals who have a long-term condition, and then what services we provide to complex long-term condition. Next slide, please. And it is really crucial that we do that because we do know that there is evidence to suggest that 10% of the patients that are seen in primary care require 40% of the GP's or primary care team's time. And what I'm demonstrating through here is that if we were to look into understanding our population need through the integrated data sets, we can then devise and design specific interventions to address those needs. Next slide, please. What our integrated data sets told us, or we found, was that patients with adult asthma have 3 comorbidities. Want to need to bring to your attention those comorbidities are OA, depression, hypertension. Patients with COPD, at least 90%, 95% of the patients had the same diseases, comorbidities. And patients with diabetes, we have around 70% of the patients have the same diseases or same comorbidities. That then begs the question, how should we design our integrated neighborhood teams? Next slide, please. So what our conceptual thinking at the moment is that we do understand that 70% of the patients on disease registers will have transactional needs. They will continue to be on those disease-specific registers requiring those services. However, a certain proportion, around 5 to 10% of those populations, if we could click the slide, please. Next slide. They would require complex care, as I said, and then how do we connect the disparate parts of the system to ensure not only data is collected, but how do we provide our care based on that data? Next slide, please. So what we have done is we have developed a insights to action framework using that, and it's in the foothills. We have only just started using our data sets to inform our action insights to action framework and working with different parts of the system. Can I move to the next slide and the slide after? I'm going to skip this slide. So really, how do we establish integrated neighborhood teams? Came up with this 5-step implementation framework where we can look into understanding. Starting step 1 would be understanding the population needs. I have talked about integrated integrated data sets, but I'm very aware of the realities of many systems where integrated data sets is not available. In that case, we need to use the data sets that we have available, and each of the GP practices does have their own register as a minimum to start off with. And my kind of starting point would be to understand the GP registers and looking into what is the data telling us, how do we move into action, designing the teams, and how do we coordinate that. Moving on to the last slide then, please, Nuj. I'll skip this slide. As a system, we are starting to look into, we know that there are many challenges, but really focusing on what opportunities we have and how do we address that. So I'm going to hand back over to you now, Paul. Thank you.
Thank you very much. Interesting. I really like the fact that you talked about the granularity of data and how it's used. I've just got one quick question for you, Malti, if that's all right.
Yeah, sure.
Could you say what are the key challenges to applying these different approaches that you've been describing?
So there are there's not one, there are many challenges, Paul. I don't want to give the impression all of this is easy at all. The challenge is that we are not starting from a clean slate. So we do need to understand the complexity, contextualize the system, and we need to really build on where we are starting rather than deconstructing. It's about understanding the complex system and then constructing from there would be is the solution as well. And the other thing that I really found having led on a number of these very complex programs is that we cannot underestimate the power of distributed leadership. Distributed leadership in complex systems really works in my experience, and we do need to tap into that. Thanks, Paul.
And that links nicely with what Steve was saying again about leadership. It's just so important.
Indeed.
Communication and good network.
Indeed,
final talk of the three. So I'm very pleased to be able to invite Sam Shah to give us a talk about his experience in digital and the challenge that he has faced. So over to you, Sam.
Hello, good morning, and thank you to Paul and Nuj and the team for organising this and for inviting me. It's great to join you, and really good to hear about some of the themes that have already been discussed this morning. I know from the items that Steve mentioned earlier, there's lots of crossover, particularly around things like shared cared records, but the other part being around the sort of strategy of an organisation. And thankfully, Multi took me back to my earlier days in public health in Kent and Medway. It's quite nice to see those areas and the data in particular around the population, something that commonly we have to deal with in digital services. So I'm Sam Shah, I am a clinician, I'm also an NHS consultant, I work in academia, and I've worked in digital transformation in different parts of the system, and have worked across local authority, public health, clinical services, NHS organisations, and the national teams at various points. And one of the things hopefully I'll share with you is some case studies of things that have happened at a local level, regional level, and a national level that might give you some ideas of where to start with digital transformation in health and care when you're going on this journey. Some of you might be involved in putting together cases, others might be further along in that. So citizens, what do they expect? And I've just put a little quote there on my next slide around citizens expecting health services to be digitally enabled. If any of you read the Lloyd's Consumer Digital Index, and I highly recommend that you do pick this up, it's commissioned by the government each year, and it just sets out the degree and the extent to which populations utilize or expect digitization in services. And that is no different in health services. And that, in our case, for health and care, is not just the service users, but is also our workforce. They all expect digitization in some form or another, whether that is their utilization of data, whether that's apps, devices, and technology, some of the things that Steve mentioned earlier on, or whether that happens to be the intents and actions that are taken in order to help populations through the use of technology. Digitization is part of what people, citizens, our users, and all of us probably now expect. Multi earlier on brought me back to the days of Dahlgren and Whitehead and the wider social determinants. And one of the things that I often talk about now is that internet penetration is one of those wider social determinants. We know that people that do not have access to online digital services generally are more likely to have poorer outcomes, suffer inequalities, and have difficulties with access more so than others, because this is now part of the way that people live their lives. But what is it that we all expect, our workforce expects? Well, over here, I've put another quote up of that I've taken from others on my next slide, which is really around digital healthcare solutions should be simple and effective. And when I mean simple and effective, we have to address three need states when we build any digital services. Whether those digital services are data and infrastructure and systems, whether it's telehealth or telemedicine, whether it's apps, wearables, and connected technology, there are three things I'd like you to remember from anything I say today. Remember the clinical needs of our users, remember the practical needs of users, and remember the emotional needs of users. And these users aren't just patients, but they're also the people working in our services as well. They're not just citizens, but they're also all of us. And remember those three things when building and designing digital services. If we can't address those three things to a lesser or greater extent, there's almost no point in starting. Now, why I say that? I'll give you a little snippet of something that started a few years ago. And on the next slide, I describe one of the many technology visions that have been produced over time. Now, I picked this particular one up because this came out in England around the Hancock era, and these were the 5 themes that Mr. Hancock and colleagues were focused on, certainly when I was working in the centre. Now, most of these themes aren't that different to all of the themes that you will find in any one of the many strategies we pick up, whether it's what good looks like, whether it's the NHS long-term plan, whether it's anything else. You'll find something in there about innovation, something about infrastructure, normally a piece about standards, probably something on digital services, and then this bit about local choice, which we also sort of see through the fuller stock take as well, around the local piece and what it means for integrated care systems and local partners. And why I share this with you is whichever flavor of government, whichever flavor of policy lead, whichever the particular intention is this week, we'll find components of this that come out. Now, the problem with this is it drives us in a certain direction. We end up with these policies that themselves are drivers, but does it necessarily mean that we're meeting the needs of the underlying population, our users, and designing for them? Not necessarily, but I'll come back to that in a moment. What I'm going to touch on now is some of the challenges that we all face. You'll all be familiar with these things. We face the regulatory complexity. You heard it from Steve earlier on about the CQC and their expectations. Now, I've registered in my time probably 20 different CQC services across health and care. I'm still a CQC provider myself, and I have to deal with about 9 different regulators on any one day of the week in my clinical work. Then we also have things like the ecosystem maturity. It varies across the country, it will vary in our integrated care systems, it will vary between health and social care, it will be very different. And we have to deal with that uncertainty in the ecosystem and the varying extent to which maturity exists. Other things, political challenges. Steve mentioned the local piece there around local government. We have to be cognizant of the fact that local government is democratic. It is made up of locally elected members. There'll be a flavour of politics there and those political challenges. Multi mentioned what's happening post fuller stock take in the integrated care system. That also, on the other side, comes with central government political challenges. These are things that we have to reconcile, that you'll all be facing, and I certainly remember very well from my days in the system, that it's not easy making change happen because it's not only your users, but it's also that political challenge. There's other things like funding. There's never enough funding to deal with what we want. Culture, the culture of change is not an easy thing, taking people on that journey. And many things center around the legacy of systems. Our systems and way of working are baked in to the way we operate and have been for more than 100 years. Before the existence of the NHS or anything else, we've always had ways of working that get baked in to the design of our digital systems. And often what we do is we transfer from what we do in the analog world, in the physical world, to the digital world when we design. We don't necessarily transform, we end up transferring. So the other thing that I would say is challenge, question whether we're really transferring from a paper or physical way of doing something to a digital way of doing something, or whether we are really transforming to get the things that Multi mentioned around those Maxwell's criteria around, are we transforming for better accessibility, availability, efficiency, and effectiveness in services, or are we simply moving the problem we've got right now around waiting lists and access to just a digital way of doing it? And all too often, we end up doing that piece, which is the latter. So I'll now share with you 3 case studies that I'll briefly go over. The first one is the local one, and it touches back on the piece that Stephen mentioned, but also what Multi mentioned around data. And certainly when I was in Camden, one of the projects we worked in back then with the local authority and with the local health partners was the first health integration engine, which at that point they called CIDR, very sort of affectionately. And CIDR was basically designed to bring together that data from a granular level to be allowed to be used, not only for population health purposes, but also to drive and build one of the first shared care records. Now, shared care records have got a long and tumultuous sort of past, partly because of who owns the data and who controls it, consent, access, all of those lovely things that sometimes plague us and will never go away and we have to deal with. But trying to get a local health integration engine up and running, there are many problems. But the biggest one that we have to overcome, and that I think is an important thing to remember, is this is people's data. It is sensitive data. And ultimately, people will feel protective about it, and rightly so. And so the thing that I'd say I learned most about that particular journey, and I'm not saying that any one of you should do it in the same way, but is about taking those local partners on that journey with you. And I can't stress enough how much local engagement is important, not only amongst the clinicians that often feel like they're controlling the data, and believe me, my colleagues out there across primary care often feel like they own the data of individual citizens, but they don't. Citizens own their own data, but most importantly, actually going to citizens, listening and understanding what it is that they're feeling and going through, and bringing in partners like local authority councillors, democratically elected people, the individuals that are working in these places, and work with them. I think I got more value out of going to health scrutiny committees over this particular project than I probably did from speaking to health partners. Because often in healthcare, we can end up being a little bit insular, thinking about the world through the lens of health, but actually there's a whole other piece out there. So I would say the most important thing is get to know who your local elected leaders are, who the health scrutiny committee partners are, who is sitting on the what was the health and wellbeing board or the equivalent now, and go and listen to their problems, understand what they are, share with them your local projects, and understand also their concerns and how you're going to jointly deal with those, because it's much more likely these local shared records programs are much more likely to succeed when that degree of buy-in exists. And otherwise, I've seen the opposite happen, where you end up with questions, challenges, and even judicial review in certain cases, and I've had a few of those to deal with in time. So I can't stress enough on those local records sharing programs, engage and involve the local community. And the thing that I probably took most from that was handing over the selection process and the procurement to local representatives. I had a group of citizens involved in a particular project, not this one, but another local one, and actually giving them the chairmanship of the appointments of the panel to actually make a decision was a really powerful way of not only involving people, but demonstrating that the local population are in control of their destiny. And this is a hard thing to do. It's not easy, requires training, requires investment, requires support, but it does result in a better outcome and a more involved population. The second one I share with you comes back to Maltese region, Kent and Medway. I remember going back a few years, I think it was 2012, analysing the flow of referrals. And if we think about referrals, they result in backlog at all parts of the system. Backlogs in the inflow, backlogs in the outflow, problems in all parts of the system, whether it's the flow in from social care into the acute setting for outpatients, whether it's the other way around to get people through outpatients into treatment, back out the other side. Referrals are a problem, and the referrals are a problem right now that everyone will be aware of. What we analysed of this particular situation was the data flow. Where are they getting stuck? What are the bottlenecks? We found originally there were 32 touch points for referrals. Now things have thankfully changed now. But this particular project was difficult because there was a national project already in place with an existing system, a top-down approach, policy-driven, that we must use what was given nationally. There was a local problem where the national system didn't meet the needs of the local users. So the system was not designed around the users. It was a top-down, you must use this system. And then we had the problem of what was actually happening on the ground. The workarounds were multiple. People were printing off the referrals, annotating them, rescanning them, emailing them, uploading from one system to the other. It was despair. Can you imagine the data quality degraded over that time? The quality of the referral from the starting point to the end point wasn't very good. And it meant that people didn't get access to their care that they should have done. That was very problematic. And the way that we sort of got around this is a point that sort of Stephen mentioned earlier, which is engaging with suppliers. And we engage with a range of different suppliers. We engage with all the clinicians on the ground, and we engage with those people affected by the problem. And we involve them in the design of what could be solutions. We then brought in a range of different suppliers to try and explain how they might tackle those problems through an open RFP process. And then we ended up selecting a supplier. And we went overnight in that particular project, almost overnight, of sort of saving 2.1 million per year immediately, and then further savings that came. And it's rare that in an NHS project, there's actual real cash savings. Normally it's non-cash releasing savings. This was a cash releasing saving. We actually stopped spending money on referral management centres, on people whose jobs that were simply to print off, rescan, photocopy, move, post. All of those things disappeared by implementing something that completely went against the grain of the national system. I had to take a lot of flack for basically going off sheet and procuring something locally that didn't meet national objectives, but the outcome was better for the citizens involved, better for the clinicians involved. It expedited referrals from what was about something like 16 weeks down to about 30 seconds. And you can see on the ground there's a difference. And I share that one with you because sometimes, of course, it's useful to follow the national policy direction. If it doesn't meet the needs of your local citizens, your local users, then sometimes you have to do what's right locally, which doesn't always mean the national format template is necessarily going to work. The final one I share with you is probably the most contentious one I had to deal with, NHS 111 Online. Everything from building it to having it implemented, everything from national policy drivers changing. And certainly when I was responsible for large parts of urgent emergency care, the pressures were no different. Ambulances stacking up, people phoning 111, 999, pitching up to urgent care, out of hours, daytime practice, all over the system. And these problems haven't gone away, they've only got worse. And implementing this was a way of trying to not only alleviate pressure from the system, but allow citizens to be able to undertake that triage for themselves and end up with an outcome in a way that was easier for them to access, but at the same time cut out a lot of that process where it could be done. Now, the challenges here were quite difficult. There were questions around the safety of systems, so going back to safety and regulation. There were questions I had to deal with around what it would mean on the ground and flow. Would it just become another channel that people would use? I had to then get into the issues of whether it was really going to alleviate pressure or not, and around other issues around should we have multiple providers, should we have one provider, should we have a limited number of providers? And we had to go through this. And the thing that did help was evaluating and data, but the biggest thing that came out of this was actually having to engage clinicians on the safety of this. And what I can't stress enough is have people who are experts in clinical safety involved in projects like this, especially when there's a clinical aspect to it, so that they can share what it is that works about a system, how it's well regulated, and how the content and the algorithms are based on the evidence, the science, and have been tested for use on people, and that they are regularly monitored and evaluated for changes with teams behind them deal with clinical risk management. It's not a simple case of picking something up and implementing it, but it actually comes with that sort of safety protocol. So I share those few things with you, but I leave you with three things that I also want you to remember, which I've just shared here on the next slide, of things that you must build into any transformation type program. The three things that are on the next slide here, the things that you should build into any of your programs. The first thing is have a strategy that spans your entire program, not just the single piece of digital transformation, but also your organizational strategy. Make sure that the digital component is built in and that it's got some length to it, typically at least 3 years. But if it's anything shorter than that, you probably won't actually be able to do anything. If it's anything longer than that, the politics will probably change. Resourcing, make sure that your program, whatever digital change it is properly resourced and funded. If it's not and the envelope doesn't match, don't do it. Say no. Don't actually go through it unless the resourcing is adequate. Otherwise, you'll only end up cutting corners and not really getting the outcome for your population or your users. And finally, the organizational design in which you operate to try and make this happen, make sure that it is all-encompassing. Because if it is isolated or only deals with one part of the system, again, the change won't happen and you'll find it balloons, a problem will pop up elsewhere when you implement a digital solution. So thank you very much for listening. You're very welcome to contact me. My details are on the next slide, whether it's on Twitter, LinkedIn, or elsewhere, but it's been great joining you today.
Fantastic. That was really good, Sam. I appreciate that. And it was so inspiring to see those examples of where you've done this in practice. It's really good. I just wanted to ask a couple of quick questions before we move on to the general Q&A, if that's all right. The first one is kind of, do you have any top tips, for how you achieve digital transformation in the NHS?
The biggest thing is start off with the need, demonstrate that need, and make it relatable to the people who will benefit. The second thing I would say is engage a wide range of clinical users, and the most important ones, clinical and across social care colleagues as well, are the people that are most likely to say no. Find out why they're saying no and take that as healthy challenge. accept that challenge is a good thing, and actually find out what it is that is underlying why people don't want change to happen. And the final one, as I mentioned, is risk sourcing. I can't overestimate how important it is to properly work out the cost of a project as far as possible, build in contingency, and make sure it's properly resourced. And if you've been told that you've got resourcing for 5 years, accept that that only really means 2.5 years. Your budget will be cut after 2.5 years. So think about what you're going to achieve in 2.5 years and upload the best things that you're going to do right up front to derive the benefits.
Brilliant, that's very good. And then kind of the flip side of that is, what do you think are the most difficult things about a national digital transformation program?
One size doesn't fit all. And the problem with a national project often is there's an assumption that the thing that they built at the top will fit everyone down at the bottom all over the place. It rarely does. And so while the national intentions are good, I think we have to move away from delivering one project for everyone and more so to some intentions for everyone, but allow some degree of localization and to exist, because otherwise rarely will the products fit for everyone's purposes.
Brilliant, thank you very much. So we're going to move on now. I just want to say thank you very much to all of the presenters for those fantastic presentations. As mentioned, this is the final webinar in a 4-part series. This slide gives a summary of the previous webinars, that we've done over preceding months, and there should be links to recordings of those webinars to be dropped in the chat. So we covered integration and collaboration back in, I think that was back in July when we started. Then infrastructure strategies were covered in August. And then last month, we had a really excellent set of talks on decarbonisation. And these talks, I think, are all available on YouTube as well.